Hello everyone and welcome to this video about what has been presented at this ESMO 2024. We are here in Barcelona. My name is Enrique Grande. I'm chairing the Medical Oncology Department at the MD Anderson Cancer Center in Madrid, and I am extremely fortunate to be here together with my friend Professor Alison Birtle. Alison, how are you doing?
I'm great, thank you very much, Enrique. So I'm Alison Birtle and I'm a consultant clinical oncologist at the Rosemere Cancer Centre at Lancs Teaching Hospital in Preston in the northwest of England.
And Alison is very humble because she is one of the worldwide experts in urothelial tumors, but particularly in upper tract tumors. In upper tract tumors, it has been presented some data about the Ambassador trial, the use of pembrolizumab in the adjuvant scenario. What did we learn from this data?
So the data was really updated data with longer follow-up compared to when Andrea Apollo previously presented it. So the original data was presented about 18 months ago now, so they have extended follow-up up to 44 months. And just to remind you, I'm sure you remember very well, these are patients who had not just upper tract tumours, in fact they were a minority of the patients, about 20%, but patients who had high risk invasive urothelial carcinoma, non-metastatic, randomized between pembrolizumab and surveillance. And as I mentioned, the upper tract patients were the minority. So we already knew that the study was positive for its primary endpoint of disease-free survival. And with extended follow-up to 44 months, it continues to be positive. And there's actually, the disease-free survival is double in the treatment arm with pembro compared to the surveillance arm. There was some subgroup analyses. I didn't see all of them. She went over them very quickly. But I did see that the upper tract patients, it was not positive. It was very wide confidence intervals, some of which were on the wrong side of unity. And of course, these were only small numbers of patients. So of course, realistically, the standard of care for upper tract is not a checkpoint inhibitor. We know from the adjuvant nivolumab study that group was also negative, and the standard of care should be 4 cycles of adjuvant chemotherapy with either GemCis or GemCarbo as per the POUT study.
And what about biomarkers? Do you think we have a biomarker to predict the relapse rate?
I think at the moment, not a great one.
PD-L1?
No. I mean, PD-L1 we know is just prognostic of, if it's high, then we know that the patients will tend to do better. But the subgroups for Ambassador, the plot was skipped over very quickly, although the publication has come out in today's New England Journal of Medicine, so all the data will be in that for people to pore over at length.
And maybe in the upper tract tumors, because of the high prevalence of FGFR alterations, may impact this data?
It's interesting thought. However, the majority of the FGFR alterations are actually in the non-muscle invasive upper tract tumours, where it can be up to about 60%. So once you get to those more invasive tumours, then the rate drops down. And we know that in metastatic disease, the rate is significantly lower than that, although we're fortunate to actually have it as a target. And that's why the Thor trial was so interesting last year in terms of changing our practice to use erdafitinib in patients who've already had 2 lines of treatment. I think the interesting thing is that I was expecting for upper tract disease with all of these studies for checkpoint inhibitors to be positive because of the higher rate of microsatellite instability, but it's not. But certainly in bladder cancer, we now have 2 studies that are positive for disease-free survival. Neither are positive for overall survival. There is extended follow-up with nivolumab, but as yet it hasn't shown overall survival benefit. The second thing that from today with the Ambassador study was that the study will never be powered enough for overall survival because of a change in practice during the study. So the FDA licensed adjuvant nivolumab, which meant that patients who were in the surveillance arm then got nivolumab, but also interestingly, some patients that were on pembrolizumab went on and had nivolumab as well. So I don't think we will get overall survival data that isn't contaminated there.
Absolutely. Let's move to the non-muscle invasive scenario. We have seen the data of the Sunrise-1 trial. What can you tell us about this trial?
So Sunrise-1 is a very intriguing device study for patients who are using the TAR-200 device, which is inserted with a flexible cystoscope. And when it comes out, it then coils into a shape like a pretzel. and it is loaded with gemcitabine at a fixed dose. And the idea is it floats around in the bladder and delivers a fairly uniform dose just in close apposition with a very tiny amount of systemic absorption. And this device has been used in the Sunrise program for a number of different indications, but this was Sunrise 1 that was reported today, which was looking at patients who were BCG refractory and didn't want a cystectomy or were ineligible for cystectomy. So they wanted to try and keep their bladder. So obviously any results also have to look at quality of life and bladder function, as well as the primary endpoint, which would be keeping your bladder. High response rates, and the study was actually one where they originally started off looking at the device TAR-200 in combination with sertulimab, or sertulimab on its own, or the device on its own. But the data we saw today showed that the monotherapy with TAR-200 was the best option, 84% response rate, complete response rate. So that's very positive. Obviously, it's early data, there needs to be longer follow-up. It did seem to be very well tolerated, so it can certainly add to the armamentary that we already have for these patients who are BCG refractory, because of course we've seen studies of sort of nanofaragene, we've seen studies of checkpoint inhibitors in this space as well. So I think there's more to come from this, but patients do want to try and keep their bladders.
Absolutely, and you know, this space, the non-muscle invasive scenario, is becoming more and more crowded of new drugs, new options, intravesical devices, subcutaneous immune checkpoint inhibitors, intravenous immune checkpoint inhibitors. So hopefully in the future, well, in the short future, I think we will see some very good data in this field.
I do think, though, there's one really good thing about TAR-200 is that it can be given by the urologists, because the checkpoint inhibitors, for the vast majority of countries, you need your oncologist. We're already very busy because of new drugs in the advanced bladder cancer setting, not to mention the prostate cancer setting. So anything that can be done by our surgical colleagues is a great idea.
It will be very challenging.
Yeah.
It will be very challenging depending on the places. And let's move to the most exciting data that were presented at this ESMO in the plenary session, the NIAGARA data, the perioperative treatment of patients with muscle invasive bladder cancer. For the first time ever, anything is demonstrating overall survival improvement in a phase 3 prospective trial in this scenario, hazard ratio 0.75. What do you think? What is your overview of the NIAGARA data?
So it's interesting because the primary endpoint was looking more at sort of the co-primary endpoints, but one of which was complete response. So overall survival data is secondary endpoint. The complete response rate, there wasn't much difference between the arms of the study. And it did remind me a little bit of a earlier phase study that we had presented a few years ago, the NeoBlade study, adding in nintedanib to GemCis, which also didn't show a very impressive PCR rate, but had an OS. OS was positive with it. So it reminded me a little bit of that. The other thing, Enrique, is that if we look at the results from neoadjuvant chemotherapy trials, things like VESPA, what was the response rate, the PCR rate with that? It was pretty similar.
Above 40%.
Exactly. So is this going to immediately change practice? I think it has to be a subject of a debate, really, doesn't it? Because if you're using a different chemotherapy regime that actually shows more activity, then it's going to come down to personal preference, patient preference, reimbursement, toxicity. But I do wonder how well it might be reimbursed if it's less than chemotherapy regimes that people are using, all of which are, those regimes are generic drugs with supportive medication, all of which is off license, is off patent and cheap.
Definitely, the NIAGARA data are going to create a huge debate in the field. The inclusion criteria considering patients eligible for cisplatin since 40 milliliters minute. So, well, there will be a debate. No, but a subgroup of patients were able to use a split dose cisplatin. Okay, but this is not the official definition of cisplatin eligibility. That would be something PD-L1 seems to not really select the best patients for this strategy. So it doesn't matter the PD-L1 expression at all. events-free survival, the other dual co-primary endpoint. So it is met, and I think it is, as well, clinically speaking, it is relevant. So I think there will be a huge debate, and of course the cost, everything, a relationship in the multidisciplinary teams in between oncologists, urologists, 40% of the patients were PT2 tumors, and it is not impacting in the survival in this subgroup of patients, and the responses were much, much lower than the comparator arm of the VESPER. So we will have a lot of debates around
I look forward to listening to them.
that. And let's talk about biomarkers. And I think the VOLGA trial, it is an ongoing trial, EV plus durvalumab, EV, durvalumab, tremelimumab versus upfront cystectomy in patients ineligible or who refuse cystectomy. What data has been presented?
So it was a small number of patients whose data we were able to share looking at the biomarkers, and it was looking at circulating tumour cells. And for those patients who started off with high levels of ctDNA and whose ctDNA went negative after treatment, they were the ones who had PCRs. For those where it was positive, it was high and stayed high, those had residual muscle invasive disease. Really exciting. However, it's really early. So the positive ones that went negative, there was only 4 or 5 of those. So it's more intriguing with more to follow. To be honest, I was more excited in terms of what I could tell my patients when the IMvigor011 study reported earlier on this year that for those patients who remained negative with their ctDNA at 12 months in the surveillance arm, their risk of relapse was significantly lower, even if they were T4 at the outset. So it was the ctDNA that was really sort of driving things rather than the pathological stage. So that makes the studies that we do in adjuvant therapy even more important, because we're looking at patients with high risk. So that high risk is defined as sort of PT3, PT4. But if they're ctDNA negative, it doesn't matter that they were T4. So that was the thing that really I sat up and listened to earlier on in the year.
These data are really, really encouraging, but I think we need time to put it into the practice. Yeah. Alison, it has been a real pleasure to be here with you.
It's been a joy, thank you.
I hope you enjoyed that conversation, and please, we are really thank you for you to attend to this video.